This first case is a 10-year-old boy presenting with medial knee pain during the past 3 months. There's no history of injury, no previous surgeries. So we can see his x-ray pictures here. In the MRI scans, we see a chondral lesion on the lateral side of the medial condyle, which is the typical situation, typical location for an OD. The interesting fact here is we've actually got a pure chondral fragment. We have straight leg axis alignment. We have an intact meniscus, but this kid is only 10 years old. So the question is here, is this something we can treat conservatively, or is surgical treatment recommended or required? And if surgical treatment is required, what kind of surgical treatment should we prefer?
Yes, so very interesting case. We've already pointed out that age matters when we talk about cartilage repair. And now we, of course, are also interested in what is your opinion and what would you like to do. And that's why we prepared this live voting, and now you can choose what is your treatment of choice.
Yeah, and it's also time to discuss this case with our international panel. So I might want to start with you, Christian, because you have not been involved in the first session, at least not live. So what are your thoughts? 10-year-old patient, pure chondral fragment.
So first of all, in a 10-year-old, if they start becoming symptomatic and they have only been symptomatic for 3 months, the first thought is to try to see if you can do a non-operative management. Based on the MRI, however, you already get the impression that this is actually a loose fragment and not just a symptomatic OCD lesion. In this case, once you are starting to have actual mechanical separation of the piece, I don't think non-operative measures are appropriate here. And you saw that in the arthroscopy images. This is clearly a loose chondral piece. So I think surgery is necessary here. At that age, anything heals, right? So to take that piece and throw it away, I think would be a bad thing to do. So my approach here would be to look at that piece, prepare the underlying subchondral bone. Typically, you have to debride this quite aggressively. And then it turns out to be a little bit deeper than you think. I do a mini arthrotomy in those cases, take a little bone graft from the proximal tibia, proximal to the growth plates, put that in as a bed, put the chondral piece back on, may use some fibrin glue around the edges, and then do a couple of chondral darts to fix it back into the bone, and that typically works.
So very detailed statement on how you would treat that patient. Martin, any further comments, any different aspects, any different opinion?
Yeah, no, I would typically use that arthroscopy to assess the bone on the undersurface of the fragment, and then if it is truly a chondral lesion, then for me, I would not use chondral darts. That is my usual fixation for a standard OCD. But if it is a chondral lesion, I would do the mini arthrotomy, and I would actually prepare the base, but then actually suture the cartilage back on, and then augment that with fibrin glue.
But no fear that we are talking about a pure chondral and not an osteochondral fragment. So do you believe in healing, Lisa?
For me, this is the main point, because if it will be osteochondral, I would for sure go for a fixation, without any doubts, as far as a loose fragment. But as far as a poor chondral, I had in my practice only 2 cases like this. And one healed, one not. We tried to fix both. And one was 12 and another one was 13, a little bit more. 10 years old have maybe better possibilities. But, you have, for my opinion, 50-50. You have to refix it, you have to try. It's 10 years old, and I prefer the technique Christian will use, so to fix it with a bone plaque. But I don't think you will have 100% of success.
Okay, so thank you very much. Just one last very quick question. So in histological studies was shown that the cartilage actually shows signs of dedifferentiation. Are you not concerned about that this might be a problem in this case? Probably, Chris, a very quick answer for you because we are running out of time.
Well, I mean, the short answer is, what do you think your graft or your MACI is going to look like in terms of the cartilage? Certainly not any better, right?
Yeah. So you wouldn't be concerned. I would conclude from your answer, and I think that's a very good attitude. Now we will see what our audience votes for. Do we have the solution right now?
Yeah, this is kind of interesting because actually I didn't expect all the experts to straightly go for that refixation approach, because in former days we learned that a pure chondral fragment has no real potential to heal, but almost 70% of our audience advocates for refixation, and that's also what we decided to do. So we will just have a look in the video from the surgery. So we don't have prepared a solution video for all our cases, but we did for that case. Let us just start the video at that point, and let's have a look in the OR. Okay. The intraoperative situation, and you really see that this there was a clear detachment from the subchondral bone, and it was a pure chondral fragment. So initially we removed that, and the interesting aspect was that this fragment was really swollen, so it was much bigger than the defect area, and trying to put it in, it was kind of an effort, and we actually shortened it in order to get it back in place. So we made some drillings, but this was definitely not enough in terms of debridement of the subchondral bone. So we did some additional sufficient debridement. I personally thought about putting some cancellous bone between, but there actually was not really a place for that bone. Here you see this swollen fragment, so that we shortened it. This can also be discussed critically, but I didn't find another solution to solve that. And afterwards we used biocompression resorbable screws in order to also put some pressure on the interface between the chondral and the subchondral bone parts. This is just the short solution we did in that case. Lisa was already mentioning that this is not a 100% sure solution.
But I think that the piece of cartilage is swollen is actually typical. So whenever a piece of cartilage is floating around in the knee, then it is swollen and it doesn't fit 100%. And I think the trimming is appropriate, absolutely appropriate. And I think what's very important is you need to do something to the subchondral bone, because otherwise the chances are actually pretty low. Just put it and fix it, then that is not enough.
Yeah.
So you need to have some biology from the ground, and then I think the chances are pretty good.
Yeah, and actually the diagnosis is OCD, so it's more or less a subchondral bone pathology.
Exactly.
And this is why the subchondral bone definitely needs to be involved in the treatment. Chris Latterman again, so what kind of device is your recommendation for fixation?
Yeah, so I do like that double pitched bioscrew too. But if you don't have any subchondral bone, I have had cases where it just pulls right through the articular cartilage. So in those cases, I have gone back to the chondral darts that have we call them smart nails, that have a slightly more pronounced head that will actually compress the articular cartilage. None of these really give you a great compression. But interesting enough, you don't need it. In the patella, if you have that situation, sometimes what I do is I'll just suture a membrane over top of it, because that is simple and easy to do. On the condyle, I haven't done that.
Martin, you actually suggested sutures for refixation, but one of the problems in these OCD on the medial condyle is that the typical location is really close to the lateral edge where the PCL insertion is. So how would you deal with that?
So in that scenario, I wouldn't have taken the fragment out, so I would have peeled it back like a trapdoor on the PCL, and then I would have prepared the bone, whether it needed bone graft or not, and then I would put the trapdoor back and then suture. My problem is the same as Christian in the sense that I don't think you get great purchase with any of the absorbable implants on a pure chondral lesion, and I worry about them backing out because there's that temptation to not put them in as deep as you would like, or on, because normally you'd put them onto the subchondral bone with an OCD, but the worry is that where do you stop that dart head? And so, yeah, for me, I prefer to suture it like an ACI graft and then fibrin glue to seal it.
But clear conclusion for that case is that all the experts agree that pure chondral is not a contraindication for preservation in a 10-year-old. That's what I take from that case, Hagen.